Current pharmacy practice are found at primary healthcare polyclinics and hospitals. This is the pathway of a prescription starting from the patient visit to clinic, and then the prescription is written after all the requirements done by the doctor. And then from 3 to 9 involved, the pharmacy department is involved. This is a typical outpatient pharmacy diagram, but we will see real photos of the pharmacy department hatch. Dealing with prescriptions at the pharmacy is the prescription is received. The presenter of the prescription, once received at the pharmacy, it is verified by whoever received the prescription, either the pharmacist or the technician. Verification about the medication itself, whether written clearly or not, signed by the doctor, and all specifications regarding the patient's identity. Then checking the items of the prescription, like the dosage, frequency, the form, strength, and total quantity prescribed, and then it is dispensed, just like that. At the primary healthcare, this is the typical hatch of the pharmacy. And we can see the opening is really a small one, cannot enhance the communication with patients. If we look at the instruction or dispensing first, there is no double check either when the prescription is received or when it is dispensed. There is no double check. It is dispensed, all medications are dispensed against prescription. Either for 2 weeks in polyclinic pharmacy, or for 1 month, or as prescribed, such as for antibiotics, corticosteroids, or flu medications, etc. If we look at the instruction, second, the pharmacy interference, it is hardly found in polyclinic. They either say there is no time for interference because it is really crowded and shortage in the pharmacy staff, or the pharmacists are hesitant to give any interference regarding the prescription. So this causing the trust is lost between the doctor, pharmacist, and the patient. If this interference exists, then it is not documented for future reference. Some doctors, they say that it is aggressive or poor communication between pharmacy and the doctors. And at the end of the day, patients are the payers for this. The medication instruction is handwritten. We will see real photo later. Handwritten or typed instructions sometimes. It may be given verbally, may not. And some medication instructions may be given by lines. You can see this is the first one, which is 1 by 1 for folic acid, 1 by 1 by 60. If I read you from right-hand side, 60 by 1. Okay? This is real. All like this. There is no medication name, no patient name. If I take it at home, I don't know whether this medicine belongs to me or to others at the same house. Or by this. This is the good instruction given. This is the best we can get, but again it is confusing. It said 1 tablet 3 times daily, every 8 hours. Whether I take it 6 times per day, as in 3 times daily and every 8 hours, or what? This is the same. This is one example. If we look at the counseling, patient counseling, there is no defined patient counseling. There is no written policy for dealing with that. With the patient counseling is included in the pharmacy work policy. The communication, there is lack of communication within the unit between the members of the same unit of the pharmacy, and between pharmacy units within the health area, and with the pharmacy, and between the pharmacist and the medical units. So this all contributes to lack or negative pharmacovigilance. We cannot detect the adverse drug reactions or adverse drug effects, etc. If we look at specialized and general hospital, this is a hatch, or this is a window for dispensing. We'll start with dispensing medications and pharmacy interference again is hardly found. No time for interference. This is all commenced by pharmacists. Hesitant in interference and not sure of the information given regarding medications prescribed, and again, it lose their trust. And if it is found, then it is not documented for future reference. There is also aggressive and poor communication between doctors and pharmacists from both sides, and patients are paid. Instruction on how to use medications, again, handwritten instruction. It's not typed, it's not computer-generated labels, like this one. If we look at the patient counseling, it's not found, or maybe hesitant counseling by individual pharmacists. There is no counseling room whatsoever in any pharmacy department, in any general or specialized hospital, and there is no obligation for patient counseling included in the policy of the pharmacy work. Clinical pharmacy, unfortunately, no proper clinical pharmacy found, or clinical pharmacology, or therapeutic drug monitoring services yet. We hope in the near future to get some of these services to complete the circle of the pharmacy services. Of course, there is individual clinical pharmacists. They are trying hard to form the nucleus for the clinical pharmacy, but again, it's not officially. Again, there is absence of pharmacy communication between members of the same unit to detect any adverse drug reactions, or even double medication being dispensed. Communication between pharmacy department and the other units of the pharmacy department is also missing or lacking, and communication with other health departments and the medical departments is missing, almost totally missing, and this is important to detect or to transfer information about the particular patients and particular medications to detect any known adverse drug reactions and any known adverse drug events. My recommendation, therefore, is to, first of all, we have to have a proper pharmacy job description describing the duties and the responsibilities, as well as the rights for the pharmacist. And this should include the definition of all pharmacy personnel level, including pharmacy technicians, because some of the pharmacy technicians, they receive the prescription, check it, prepare it, and even dispense it. So in the pharmacy job description, we can have the chance to identify any adverse drug reactions, because one of the pharmacy job description jobs or duties is to detect or to counsel patients on his medications. Written standardized policy for dealing with patient and patient counseling. We have to set short, condensed courses for pharmacists. There are basics, principles, and rules of clinical pharmacy, clinical pharmacology, and therapeutic drug monitoring for better pharmacy services and patient safety. To encourage the current pharmacists to enroll into clinical pharmacy courses, even by distant learning studies, or to send them to, for example, Jassar, to train them on how to detect any adverse drug reactions and how to reach the detection. We have to show them, the current pharmacists, the importance of patients counseling in the drug safety, and rewards may be given to those pharmacists who are enrolled in such courses. We have to have immediately counseling groups for warfarin, for anti-diabetics, because we have the higher population having diabetes mellitus among worldwide, and anti-hypertensive counseling group as well as painkillers counseling group. Those counseling groups should be ruled or should be responsible by well-trained pharmacists and should be well-equipped and also connected to the medical medical unit at which the patient is referred to, so that all information is between the pharmacy. Any detected adverse drug events or adverse drug reactions can be transferred to the medical unit, either online or by papers. Communications, we have to enhance communications between pharmacy members and pharmacy units within the same department, and pharmacy and all medical departments, and between all pharmacy administrations, and between pharmacy administrations and health areas directors. Immediate introduction of clinical pharmacy, clinical pharmacology, and therapeutic drug monitoring services. That's to contribute to detection and avoid and minimize the number, the duration, severity of adverse drug reactions and adverse drug effects. We have to form permanent committee or endless committee, higher committee, for identification and updating cases of adverse drug effects and adverse drug reactions, which should be joint committee between doctors and pharmacists, and the members of this committee should be higher educated doctors and pharmacists, and should have the authority over the counselling room to collect any detected adverse drug effects and adverse drug reactions. And it should have well-structured work plan and requirements, and responsible for all cases of adverse drug effects and adverse drug reactions, like detecting, assessing, monitoring, regulating, prevention of adverse ADEs and ADRs. And should have an archive of ADEs and ADRs reports sent on regular basis from all counselling room and from all medical units in all hospitals and polyclinics. After that, we can launch or we can establish the formulary with known ADEs and national formulary with known ADEs and ADRs should be updated annually or whenever required. This is an important part, which is the establishment of a drug information center, should provide 24 hours per day for all parties, including doctors, other pharmacists, patients, nurses, and should be under the responsibility of a well-trained pharmacist. Establishment of poison center we don't have yet, but we are hoping to have it immediately. Should have well-trained pharmacists, should provide information solution for overdose toxics or other chemical problems, and should have a solution for that with 24 hours per day. Then we can, I really suggest after we have all this recommendation being done or being put into the pharmaceutical service, then we can ask the School of Pharmacy at Kuwait University to involve a subject title, importance of reporting the pharmaceutical chemicals, ADEs and ADRs in student education scheme, and to enrich the curriculum with the clinical tutorials. We have to deepen the public awareness of the importance of knowing the ADEs and also reporting these ADEs and ADRs through this information should be given to patients either on the spot on the pharmacy unit or through the newspapers, TVs, and media. We can call patients' attention to the importance of reporting these ADEs, any of the detected ADEs and ADRs, on every visit to the physician or to the pharmacies as part of the counselling carried out by pharmacists when dispensing. After that, we can admit that the pharmacy is a key informant profession in the safe use of pharmaceuticals, and we really contribute to medicine, highly contribute to medicine safety. We don't want to see more side effects of unknown side effects. The patient cannot really report it, or when or where to report it to. And we don't want to see patients preferring the original disease or disorder than the side effect of his medications. I want to forward my special thanks to all pharmacists who are trying hard as much as they can to enhance the pharmacovigilance anywhere in the Ministry of Health. And thank you.